Tautonu o umwana pai lango. Ile taitsa ayo le aso. Good morning, everyone. It is a pleasure to have you here at the 2026 Medicaid Summit. My name is Cordy Talawenga, and I'm here to discuss a program that has become a cornerstone of our community health efforts since it launched in 2022. The American Samoa Medicaid Vision Care Program. When we designed this program, we wanted to go beyond just providing a pair of glasses. Our services include comprehensive eye examinations, eyeglasses and contact lens fitting, and expanded optometry services to broaden the types of care available right here in the territory. And the last detail of our providers and beneficiaries to remember is the renewal cycle, which adults are renewable biannually, which is every 2 years, and children can renew annually, and this ensures our youth always have the visual tools that they need to succeed in the classroom. Okay? For the registration process, efficiency is key to patient care. So we have simplified the vision care registration into a clear 4-step process. Step 1 is enrollment. This starts at the Medicaid office. Diane just presented a great presentation on eligibility requirements. Step 2 is screening. Our team will then screen these documents for eligibility, and then it is our intention to promote a smooth approval process so there aren't any delays in care. Step 3 is notification. Once a beneficiary is approved, we will inform both beneficiary and the provider, which is my vision, and this ensures everyone is on the same page. And the last step is step 4, care and billing. Finally, the provider and beneficiary will schedule the appointment. The patient will get their exam and eyewear, and the provider bills Medicaid directly. Next slide, data analytics. To wrap up, let's look at what this program has achieved from May of 2022 through March, through this month. The data tells a story of incredible growth and community trust. In 2022, we hit the ground running with 1,072 beneficiaries. We had a quiet 2023, and then we saw a massive surge in 2024, reaching 1,821 individuals. Even looking at 2025 and our early numbers for this year, it is clear that the momentum is clear. To date, we have a total of 4,100 approved registrations. If you think about that number for a moment, it represents 4,000 residents of American Samoa who can now see the world more clearly. They can perform better in their jobs and navigate their daily lives with confidence. As we continue through 2026, our goal is to maintain this and ensure that every eligible person in our territory knows that the vision care is a right and not a luxury. Thank you. Oh, no, not thank you for your time. I'm not done yet. Okay, so this concludes my presentation for the Vision Care Program. And then moving on to our next program, which is a relatively new program, Orthodontic Dental Program. Okay, so this program is specifically designed for our youth. Our beneficiaries are ages 20 and under. The most important takeaway here is the standard of care, which is medical necessity. We focus the treatments that are essential for oral function and the overall health of the child, which is important to communicate this to our families. And for purely cosmetic orthodontics, we don't cover that under this plan. So we handle 2 types of cases, which is new treatment, and then continuation of care. Registration process, we've streamlined this into a clear 5-step registration process to ensure we don't miss anyone. Okay, step 1, it begins with the parents or guardian to submit those documents to our office, the required documentation. Step 2 and 3, once we have these documents, our Benefits and Eligibility Division will register the child in our QuickBase system. From there, the application moves to a formal review by our eligibility manager, our Benefits and Eligibility Division head, or our deputy director. Okay, step 4 and 5, we are committed to a fast turnaround, so the goal to notify both the provider and the family is within 5 business days. Once approved, just like the vision, we issue an official confirmation letter or phone call, and then this gives you the green light to go ahead and schedule your appointment. Last slide. Okay, for data analytics, finally, if we look at the impact we're having, these numbers represent the hard work of our team from April of last year through today, March 2026. In the 2025 calendar year, we successfully approved 310 eligible beneficiaries. Moving into early 2026, we've already added another 68 to that list, and that brings our total approved registrations to 378. To us, this is a significant milestone for our office, and this means that 378 local youths are receiving specialized dental care to improve their quality of life. As we move forward, our goal is to keep consistency and continue growing these numbers to serve eligible child in our territory. This concludes my presentation, so if you or someone you know can benefit from our program, please send them our way and we can help them see life better. Thank you for your time and for being here.
Ia manatu o vela foi fala ia to watu lava le limo le fatalofa le malu mo le pai o mafai ona poto mai le nei tai au tai manuia, and good morning everyone. My name is Letu'uala Sulu, work as a benefits coordinator. Ia mo le temi nei ia I will be talking about the DMEPOS program. Pe o le plokalama le look forward o mai ia tangata le tunu e mai e wawa ai DMEPOS program, durable medical equipment, prosthetics, orthotics, and medical supplies. This program started in 2018, and it helps provide important medical equipment to patients, such as wheelchairs, hospital beds, walkers, prosthetics, and other medical supplies. O le nei plokalama I whai tele sina tā ua. Ia wā le mamalu o whapea whaina i o tātou tangata mai le tuina atu lea po le whaawanoa ina lea o medical equipment po mea whaingaluenga whafo mai e sosoani e fo I lātou soifua malolo ina. Medicaid, DMEPOS Medicaid coverage. I think this is the most asked questions. Alwatu nei se beneficiary e fisilia tul mato officer. Why is this equipment not fully covered? O le me le kavai, le kava atoa, le lo me fo suka, o le me le kava atoa, lo to. Yeah, o le tali lea, Medicaid utilizes the Medicare fee schedule for DME. So that's why some DMEPOS program, equipment requires a co-payment. Moving on to our next slide, which is the important. These are the steps or the process to ensure a smooth process. Ia me se fo ile le whanga soloina o le tātou prokalama o le DME. The first step is LPJ or DOH doctors issues prescriptions to the patient. And these prescriptions confirm some medical necessity of the patient. Pe ole prescription lea, e a mata ile process. E confirm mai po lea le tua ngā equipments po ole mea whaingaluenga whafo mai fo e mana o mia ele patient. Moving on to step 2, patient takes prescription to DME provider for application. Ia umalo na maua mai le lau physician po le fo mai fo i le lau prescription. Ia na e alusa o la ia i le to one of our DME providers e avi e lau prescription. Maua mai lo le application. Ia ona tatua o mai lo la i le step 3, patient registration at the Medicaid office. Ia pe ona sau noa tu fo i le tamaita ia Portina ia Diane. Ia lea e ngafa malinga luenga lea o le ia atua mai uma ia required documents. Ia wale reis talaina i le blokalama. Moving on to step 4, Medicaid screens and approves DME requests. Ia le nā fo ia ngā luenga fo ina le eligibility. Ia review ina ia applications ni. Ia wale afo le request from the beneficiary. Moving on to step 5, DMEPOS provider schedules delivery and bills Medicaid. Ia nā e afo e notify e loa ele mata ofisa ia providers nei. Ia e a mata loa ona kiliva ia medical equipments i tātou beneficiaries. Ia ma le step muli Medicaid conducts visual audit of the DMEPOS delivery. Ia, at this step, a Medicaid representative will be present during the delivery. It confirm mai pe sao le afoi ia le DME equipments le tiliva ia for itato beneficiaries. Just to go through all the process here, this is very important. Telefoina tangata watu le officer. Ia e whamatala atu foi ma avatu foi nisi o complaints. Ia a le follow itato process nei. E tuai lava na kiliva atu ia le tato equipments. So step 1, prescription. Step 2, registration at the office. Step 3, patient registration at the Medicaid office. Step 4, Medicaid screens. Step 5, DME POS provider schedule delivery and bills Medicaid. Ia mali step 1 muli. Ia le confirmation leo wa kiliva uma ia tato medical equipments. Yeah. Here's a look at the data summary of this program. Ia na mata mali nei blokala mai le luafes fuluiva. Ia o mai nei tausanga. Ia wa atua i nei le ono se lau, ono se fulu. Ia tātou beneficiaries. Ia o mawhai ona tiliva atua ia nei mea whaingaluenga whafo mai. Ia wa foi le soifua malolo ina ia si o tātou atunu. A eni si Fasili, ia le I le mātou team, Division Head Jeremiah, and the rest of the team here. Whaftai malova noa, manuia lava nei asu.
I would like to thank you, our team, hardworking team, for presenting the workflow, the processes that they go through every day to notify any potential beneficiary or anyone that walks into our office inquiring about the different programs that we offer and the services that we have for our community. O te toefia au mai lava le manu lauti o le nei aso. E whaapea ne I oto lo pulo ua tō wanga. Before we dive into this program, which is one of the biggest programs in the Medicaid agency. I just want to share with you the theme for this year and how it relates to the program, the services, the workflow, the processes that we handle on a daily basis. Ole manulauti nei otolo pulo wato wanga a whawhaingo fie ta pena le noa ni tuai. Or, em whaiona whaapea, lau malanga ni timu ia, ono le ta pena le. O se whaamanatuna le ofisa le ni aso. O le tele o ngai o inga, ma whaatinonga tātou nei, i le tātou loto I whale. E whaatuatua na I lava le soifua malolo inga. E tele na malosi le tū wha Europa, ma le tū mai whafo. Ai whaatuatua na e lo ola soifua malolo inga. Now if you look at the map that's on the left side, my left side, and you enter in, you had a red mark or a blue, whatever color, and you had to pin it on the village that you're from. You see how remote we live in this island. And the healthcare system, like what Dr. Tar shared with you, we're walking into a broken system that does not talk to each other. Now we have to identify the reason or the rationale behind these systems not talking to each other, because the person that comes down that really affects from it, it's us. Ole ola le mala malama, ole le ola tu fisini, po le meo tonu masao ngai o inga lo fai. There's no coaching, there's no training, proper training, how and what we should do now before it is too late. And that's where the theme comes today. Lo malanga ni timu ia, uatuai. Now I'm going to share with you our off-island Medicaid referral program. I just want to make sure that there are two different referral programs. There's an LBJ referral program, and then there's a Medicaid referral program. I'm not going to speak on LBJ because that is their own program. But today, I want to share with you about our off-island Medicaid referral program, where a lot of people have questions and inquire about this service. We do get a lot of bad feedbacks as well, because at the end of the day, we will take it. Bad or good, Medicaid agency will always be here to serve our community. The Medicaid, the off-island Medicaid referral program is medically necessary services not available on island. So there are services that are not available at LBJ for treatment. That's why the Medicaid off-island referral program is available to the community. Off-island Medicaid referral program to New Zealand includes eligible patient beneficiaries who are referred to New Zealand that are vet through our eligibility division. And an off-island Medicare referral program, if you have Medicare insurance, MedQuest, or Aloha Care in Hawaii, we highly recommend to have you referred to Hawaii. Like I said, there are two types of patient referrals. We have the urgency referrals, and that is the explanation that's up there. Got into an accident, and the patient immediately risk of loss of life, vision, or limp. Prime example, it can be the accident that happened in Afono, the fire truck that got into the side of the mountain. Medicaid was able to refer that patient to New Zealand. That is considered a medevac. Then we have our non-urgency referral. This is an ongoing referral that comes from LBJ, and we will go through the process in the next few slides. There is no referral that will be prompted or initiated by Medicaid office. All referrals, non-urgency, has to start from LBJ. And that's where the confusion is right now with our community. People think, they call our office saying that, they've been waiting for the referrals for 2 weeks, but we haven't received anything because the referral process starts from LBJ and then it comes through us. Again, Mrs. Leomiti already shared the requirements for the Ainga Care Initiative for the other programs, but this is the Ainga Care Initiative for our Medicaid referral program that includes CA and AA. Again, if you see at the dual eligible, we have a dual eligible program where your primary insurance, MedQuest or Aloha Care will take care of your visit, and then whatever bill that's left, it'll be coming through our finance team. And then we have our New Zealand Ainga Care Initiative referral program where we vet through the level of urgency. Again, once we receive the referral document or referral from LBJ, we have to go through the referral and identify what level of urgency LBJ has assigned to you. We do not assign any urgency level or change your urgency level. Again, everything has to come through LBJ, and we have our clinical director, Dr. Annie, who does her review regarding these aspects of your referral. Offline Medicaid referral coverage. These are the services that include, and we will be able to take care of it once your referral comes through and it is approved by the Medicaid office. We have your accommodation, your ground transportation, and your medical cost. We do also have escorts who will be escorting you to your final destination, whether it's in the States, Hawaii, or at New Zealand. Now, the escort is also recommended by your primary referring physician or Dr. LBJ. Again, Medicaid do not determine or make any decision on whether or not you should have an escort or not. And these are the eligibility requirements that we would require and look out for. Again, this is all part of our clinical director's review before approval. And this is the process that I was referencing earlier. The referral comes from LBJ and it gets to us, it vets through our eligibility division for eligibility verification and determination. If it gets approved, it will be reviewed by our clinical director, Dr. Annie. Once all is done regarding eligibility verification determination and the review by Dr. Annie, it'll then be sent out to our service providers. We do not send out anything to other providers who we haven't signed any provider agreements with. Once we send that referral to them, they will go through their eligibility process as well, and then to check in with the physician or the availability of any doctor pertaining to the primary prognosis that's on the referral document from LBJ. Once they get an approval from these doctors, they'll get back to us with a list of appointments or welcome packet, notifying us that these are the availability. If the patient is able to travel over or the availability of the patient, then we will confirm and call in the patient for further consultation. The reasons for denial, these are the basic reasons for denial. We do not, I just want to remind you, we do not just deny you because we don't like you or you're not in favor of the Medicaid office. That's the assumption that we sometimes do get from our beneficiaries. We do get a lot of calls saying that, "Ay, but if you feel officer, I'm only approving all a referral." No, I just want to let you know that these are the reasons why your referral may get denied, and we do issue denial letters from our eligibility division stating the fact or the reason why your referral may be denied for that purpose. And that concludes the benefits and eligibility presentation this morning. I hope everything was out there and what you are inquiring about. I know this is the bulk of your presence today, and I am assured that our team will continue to provide any further clarifications as we go along with the further presentations today as well as tomorrow. Thank you.
So this is our Q&A portion. I know that was quite an earful, but just to recap, we've learned today about all the benefit programs at the Medicaid office. We heard and listened to the presentation about the Vision program that's available locally with Dr. Laloasi's My Vision Care, being the only optometrist on island and having that service available to our people. She is one of our providers. So we heard about the Vision program, and you saw the steps to getting these services and who is eligible. Just to recap on the eligibility, by a raise of hands, who is the first, who are eligible for Medicaid services on island and off island? U.S. nationals, U.S. citizens, children under the age of 21, and then foreign pregnant women who are lawfully residing in American Samoa. These are for local services. And all these different categories, they must live in American Samoa. Now, if you are a U.S. national living in the States, are you eligible for American Samoa Medicaid? I don't think so, because if you're living in California, you're eligible for California Medicaid. Now, if you are a U.S. citizen living in Washington, are you eligible for Medicaid here in American Samoa? No, but that's the misconception. Just because you were born in American Samoa, you just automatically feel like, okay, I am eligible for American Samoa Medicaid. No, each state has their own Medicaid. And like the states, American Samoa has its own Medicaid too. And we have to screen for eligibility, as Diane mentioned. Now, how do we verify if you are a resident? Well, in all honesty, when I was in this division, I pretty much knew everybody that lived in American Samoa. We are not a big territory. Now, the only time we really go into depth with our screening is when there are suspicions like, I've never seen this person before. But majority of us, I've seen almost every one of you here at some point of my life here in American Samoa. Now, we would ask you for your driver's license, your voter's ID, proof that you live here, maybe your P.O. box, a bank statement, Azteca bill, whatever you can provide to us. Because we understand we also have some elderly people who are bedridden, and the last time they took a photo ID was back in the early 2000s. Now, how do we verify their residency? We gather all their old IDs, and we're able to visit them at their home sometimes, if they allow us, just to verify that they do live here. Now, you also heard about the Orthodontics program. Orthodontics is just a fancy word for dental. And this program was initiated last year, and it's been a long time coming. And now we have a provider that offers the services for our kids, and it's basically for our kids, ages 20 and under. And what do they get? They get to go and visit Island Smiles with Dr. Toko and Sema, get a wash, if you need braces, and whatsoever. And we encourage our kids to go. but just to have that checkup available to us, I believe it's a pretty good service for our children. E matutua ifo ia ua te tulo na wa sa sao nei nifo ia ma oloa ia ma nga awan lumana. And then you also heard about the DME program, the medical equipment program. And a lot of our people, they need these services. The medical chairs, the wheelchairs, the semi-electric hospital beds, or the mefuasuka, whatever, commode, shower chairs. There are a lot of equipments that MedQuest Supplies at the plaza provides. You just have to go out there and see for yourself. Now, I do know the process can be a little tricky, and we're working on that, because if you get a prescription from DOH Tafuna, and you have to drive all the way to Pango Plaza to get the DME application, only to come back to Tafuna for your physician to sign, and then to the Medicaid office, I can see where the complaints come from. But at this time, until we figure out a better process, those are just the steps we have to follow. If amado ruai nei tangata matutua, so tele ia nga ia to the officer, te wo lena va, adu oi pang o sau Tafuna, so e adu fangatongo. And therefore mana o mia na mai se meri mai oi I fangatongo, yeah, totally understandable. At this time, we are currently working on streamlining those processes in a ia whaafaingo fie mo tātou tangata. And then the OMR program, it's our most sought out program, and it's the biggest program in the Office of Medicaid. The Off-Island Medicaid Referral, we understand known at DH Jeremiah. Where does it initiate from? LBJ. Yeah, on a uniform, the Office of Medicaid. We are merely just an insurance office. At the end of the day, Medicaid will insure. Yeah, I would tell you that I sing a duenga with fire officer in a ia maue tato tangata tautua. Saudon every from at LBJ. Ilo atu, you are a U.S. national, you are a U.S. citizen, you are a child under the age of 21, and you are living in American Samoa. Ya no winga na ia nga ia to New Zealand, ya po Hawaii. If I ia talavai. Yeah, so recap now on our tende tato proclame ese wa fa'ala wi lo nei aso. Yeah, ale na sa inga lava ia adu ese atu tato fear that you leave here knowing and understanding the different programs and eligibility requirements here at the Medicaid office. Now, without further ado, we're going to go into Q&A. Sure, Director.
I am a Rabinoa, but I had spoiled officer Malu from Malamanga. O le affiliate ma veterani, o la facili fa mole mole. Fe me fa le mato veterani pa mato atu ele refer atu ele VA mato e mato o ala ele TRICARE pole Medicare e ma fa ele Medicaid na cava le 2%.
Of China va facili. O se facilita ua lava watu ina mai e sunga de fatonu ya inafo. E winga ia tātou tangata e iaile me ta ole dual eligible. Dual eligible no winga tele iau insurance. You either have Medicare as your primary, and for a majority o tātou watunuu who are veterans, you have TRICARE. O le fisili na utu ina mai, pe afa pe malanga ia if a veteran is referred by, okay, so I think the easy answer is if you are being referred by the VA for your normal veterans appointments, Medicaid cannot cover. But if you go through the process of getting a referral from LBJ, now I understand different veterans have different benefits. Some, and we have, as a matter of fact, we have a patient right now who was referred by LBJ because his benefits does not cover all his medicals in Honolulu. Now that we can cover. When you travel, but we just need to work together with the VA that way you can provide, right now we're working on verifying if this person is really okay. Ede o selau pasini, ya ono tato tangata. Evo idvaeng ati nga lava na selau pasini. Ya leto yo mai lava to evatsu le sitama idos food pasini. Director, the mic.
Se whama malama tasi atu ala le penunumi mai le ai o veterani e ai le Medicare ma to iau kali ia sangalemu. We cover under Medicare, TRICARE for life. Ma le Medicare, 80% Medicare, 20% TRICARE. So laki ai la kako malo la ele o pili ai mako la e cover mai le CMS. Pa o le case lea whape refer mai le VA doctor mako whape paingi mako appointment I o ngai le o ngā whakia le clinic o ngai ngala le mele kupungei. Cause I got bill e pili e saua o le refer mai le authorization mai le VA e pili mai le LPJ a taunga pili le VA mako foi le whape maua mako pengi wha mole. We serve and we deserve. So foi ngale. O mela lele ka fama tia mawai sa fama malamanga. Langa asavali le kulengi ko on pan mai. Le ai sa Medicare. Kaunga kava le pidi le local. Al Medicaid la le ke fia mama la mai e mafainga step in Medicaid e kava le part le ale LPJ.
Okay, now, given that now we may know the process there on the LPJ referral, yes, Medicaid is the payer of last resort. Umanopo alava mem faina kava in a TRICARE, more na veterania le ai alato Medicare. Yana o mai donen maso office pe ava pena na we are the process there on the being referred by LPJ.
Okay, o le refer la le fali fafo. There's a lot of veterans maliliu ko kong whakarikali le ave fafo. Le process le VA le male LPJ. Le mawhainga move in LPJ until, the VA, le LPJ. I say long I approve my fafo me le VA. Ke mawhaia le Medicaid nga so soangi le kulengi o le LPJ pa mai se request and need the kulengi le help to move them downrange for further treatment.
So Medicaid is similar to VA appointments. They are accepting physician, we cannot send. So we move once there is acceptance from Hawaii or now Hawaii de fai paanga America Samoa. So we would be on the same boat of what we are to send the veteran or to acceptance a facility that is willing to accept this patient. We would probably have the same, but we are open to exploring that option because you would probably send your patients to Tripler and its partners. And at the moment, we can try and look into Adventist Health Castle, who is one of our providers, Straub, and Queens.
Taitele lava atonu yese taimi langa tele au pesili ai la alwa ita tu te paptaia mai fama malamanga.
Ele a faina lava stunga patonu o lo ava no foi ia le officer stua tuai ia awase fatanta noanga. Okay, we have one question that was submitted on the QR code. If you notice the QR code in front of you, you're able to submit questions anonymously. Are people dealing with addiction, such as substance abuse, eligible for a Medicare referral to receive rehabilitation? I believe the question is asking for a Medicaid referral because, yes, we do not deal with Medicare referrals. Eligible for Medicare to receive rehabilitation. The answer is no. Tila, did you want to speak more on this issue?
Hi, so we don't cover addiction for off-island medical referral services, but what we do instead is we cover it through the Department of Health, Community Health Centers, and the LBJ Hospital, because we do not have a good pipeline to refer these people. And so that we are looking for like telehealth options. So we are exploring, but unfortunately we're not doing any off-island referrals for addiction services.
Question here?
Thank you for the opportunity. My name is Jilla. I'm representative from Sailua Medical Corporation on the island. And I was wondering, we are currently collecting signatures on a petition to cover hearing aids. We have an audiologist on our team, and I don't know if the process needs a different approach or a petition is good.
Thank you. So there is an audiologist on the island now?
Yes.
Okay, and is it an established provider?
Yes, they assist DOH and through the Well Baby program, and they are licensed here in our island too.
So Tina is well informed about provider enrollment and agreements. So I believe a petition is not enough to be a Medicaid provider. There is a process that even MedQuest Supplies had to go through, Island Smiles had to go through, and Vision, in order to become a Medicaid provider.
Sure. To answer your question, hearing aids are covered. Unfortunately, the way the state plan is written, only LBJ can cover those services. So how we can fix that is we actually have to amend the state plan. So we can meet later to talk about how to amend it.
And we will be learning about state plan amendments later on today. We've had to do a lot of state plan amendments in the last couple of years to include services here that just were not available. Before it was just LBJ, and then we onboarded DOH, and so forth. That are now available on island, it's a amend the state plan. Include a services here. Any other questions for benefits and eligibility, Tina?
This is my first time here at the seminar, and I'm very enjoying it. But all of us, I have a ole page mulmuli ali na faali may mga reasons for denial. Ole point mulmuli for ile fa may ole weight, shoulder with limitations, width limitation, etc. Yes, if I'm may lala, MF I'm more la.
For our providers in New Zealand, and I know Andrea, sorry, I said Emma earlier. Andrea, who is from New Zealand Air Ambulance Services, can attest to this. If it is a medevac patient, and one of the main questions, if it's sitting here in the medevac, ole shoulder to shoulder width, ole weight, ono tulanga, wa yai lava fai to afa pitoa o va too low lava, and sometimes to avoid bringing the medevac and our patient does not fit into the medevac. So that is why they keep asking. Andrea, did you want to speak more on, since it is a requirement? And so every medevac patient that we send, before we send the coordinators, it's one of the main things that they ask. So LBJ, we work with LBJ physicians and the nurses to make sure that our patients, and then if not, we can order the bigger plane. Then we just have to be creative. And honestly, in all honesty, Medicaid has been creative all these years trying to mold this program to where it is now. Andrea, did you want to speak? You were asking, so one of the reasons for denial of patients is the weight limitations and width to shoulder width measures.
So just with regards to sending an aircraft up here, the aircraft door of the air ambulance that normally comes to American Samoa is actually quite narrow. And as Austin referred to, there's no point in sending the aeroplane if we can't get the patient on. The aircraft stretcher also has weight requirements, and we also need to be sure that we can get the patient loaded on and off the aircraft safely. Obviously, we don't want to drop anybody. And there's different loading ramps and requirements at different ports where we're going. So up here and back in Auckland usually. So the widest measurement, whether it be shoulder or be hips, it doesn't matter, we need the widest. We do have a couple of bits of equipment that we can help. We've got a bare air, which kind of envelopes the patient a bit to help them get through the aircraft door. Or as also we've got a larger aircraft which does have a different door, but it's really, really important, and obviously it's hugely expensive if we send an aircraft up here and then we can't get the patient on board. If they can walk on, it's totally fine, but if it's a stretcher load, we need them to be safe and we need them to be able to get on board.
Now the question that comes out of this issue is, oleana the solution and Medicaid if I because they are our brothers and sisters, aunties, uncles. Now, what we do is usually the physicians, we're going to use New Zealand as an example. The physicians in New Zealand will provide a nutritional diet. In the next couple of weeks, get the care, the care that they deserve and is also needed. And I think it all ties back to our theme on the prevention. Before you get to that point of prevention, but then we are at this point, what do we do now? So, on the solution, we work together with medicists on ways, I believe there are some supplements that some of the patients would take, and then in less than 2 weeks, you are slimmer than normal. Director Luisa?
Deputy, could you ask or talk about why a medevac patient would ever walk on to an aircraft? And maybe Andrea can share, because we've received criticism as to why we would even air ambulance a patient if they can walk onto the aircraft. Andrea, here's the mic.
So obviously the medevacs that we come up to get people out of here can have a varying range of conditions. I'm just trying to think, there are definitely some patients that potentially could manage 2 or 3 stairs. They're still going potentially for life-saving surgery, maybe a cardiac patient or someone, they still can take a couple of steps and then they would be transported on the stretcher fully monitored. But they can manage that initial couple of steps, or fully ventilated, or unconscious patient, then they're a full stretcher load. But yes, there will be some critical patients that do need life or limb saving, either care or surgery, that potentially could move walk up a couple of steps. We just, the biggest thing for our team getting people onto the aircraft is safety. We don't want anyone to fall or not get on the aircraft safely. So it's very, very important to the medical team that we know exactly who we are trying to get on the aircraft, and safety is the number one to get them on there and keep them safe for the transport.
Thank you, Andrea.
It sounds to me like give up a proclama. When that comes in the form, it's up to us to report to those people that this person is a certain size. We are Polynesians. We're different sizes from most of the world. And as our prevention, we have to look at that but we couldn't because it's there already. We are big. So when you're making the report and you're wondering whether it's going to be disapproved, so and so size. Why do I know this? It's because of the gaming of my we went to the hospital and they had to change because of his size. So don't give up because we're going to have to tell grandpa or grandma put it in there and make the call and say, hey, this person is so and so. We can't change that, but we need to send them out. I mean, this is not for, normally it'll take time for us to look at prevention and be upriver. But in the meantime, we got to get our people there and get something and do something where they will be able to have the benefits of what this program is. Because I am twice Medicare has helped in my life.
Hey, Lava. Moni Lava Noanga. To the point, unfortunately, the aircrafts that we have on board as providers, but or the solution now, because even if we were to, and I think also Ashley can speak to this, even if we were to get this patient, say 400, 500 pounds to New Zealand, it's to operate and do surgery is very impossible. So Ashley, did you want to speak before Dr. Annie?
I'm going to have to apologise because I've actually lost my voice a little bit. But yeah, you're right, Austin. It's not nearly impossible, but it comes with a lot of risk. And obviously we need to weigh that up before we bring them over to New Zealand. Yeah, it's risk. It comes back to safety again for the patient. So.
And Moni, naman sa unuanga, o de final for your officer, we will keep, pushing back, as Ashley can attest. O de ala verify mai, o de I push back at you ono la lofa for iye tato tangata nuuma. After Dr. Annie, then Director Tafa.
Thank you, Ozzy. If I might add on, o tuainga ngasengaseia sa talanoina o ngasengaseia whaafuase e o mai temi nei e le iai lava se ngase o tinai e ave le medevac tu salava pe o vapauna pau le mea ia ofi tonu le vaadele masa uni lei ia le au whainga luenga mai New Zealand i te iwa iei se whaalave tupu a o isi mai e tinai onga o le tele o le paunga po le tino puta o mai ia le fia ave New Zealand whaia CT scan MRI. Unfortunately, these machines have weight limitations. So ele mawhailai tātou na vatu tātou whase lau paunga. Ia ale weight limitation ale masingi ngā le kolu se lau. But it doesn't stop there. E su e lava se masingi e ofia i o tātou tangata. But that is, some of the cases were denied. O ngā e mai ua whase lau paunga. So it's not only medevac, but also the regular referral patients le ave whaf. Lo whaaloa lava whaftai.
Tafa, Director Tafa, Monina.
So Dr. Fuyava had just answered a part of my question. My question would be more of, if I have a disability in regards to my knee and knee surgery, the waiting for this service to get approved, my weight is now accumulating pounds. Medication given to me also has side effect that has made me gain more weight. And obviously I'm being denied because of my weight, width, etc. being a provider, so I think you covered it earlier, you have to be approved provider in order to be covered by Medicaid. So what is the plan if I'm denied because of the condition of my disability to ensure I'm getting immediate medical attention while my health, physical appearance is starting to take a toll of my life?
Thank you for the question. Dr. Annie?
Mana ia tātou pisili lea, a whapea o o tātou tangata se tūlanga whapea. Wale mawhai e New Zealand o na taliaina o na o le tino puta foi. E iai le me ta o le teleconference, e recommend loe mātou ia whatalta noa mai fō mai mai New Zealand. Ia ma fō mai ia o lo ngā whalwa ingo ngase i le LBJ. Pe iai lava se awala. E mawhai ai o na fua ia le whaafita auri lea. So just because you get denied because of your weight, we don't stop there. We recommend telemedicine and we'll go further just to make sure you will eventually receive the treatment that you deserve.
Also, I think part of Director Tafa's question was, you received the referral for your knee, and then because you were waiting a long time, you gained some weight. Is this correct, if I'm comprehending? Normally, when we receive the referrals from LBJ, and say, for example, we'll use Director Tafa's case as an example. If we receive, it's an orthopedic referral, your knee replacement cannot be done here. You need immediate transfer to New Zealand, again, as an example. Normally, you would probably be gaining weight if you're waiting at least over 3 to 4 months. Hypothetically, our patients are not waiting 3 to 4 months because at the 4-month mark, you would need a whole new referral. The person you are 4 months from the date of the referral is not the same person you were, and that is why we require. Now, some of our patients, it delay the referral because, okay, I don't want to go next week, because next week is my mom's birthday, and then following is my dad's Salfa'i, and then Mother's Day is May, Father's Day is June, July, we have a summer camp. How about August? You're delaying your referral yourself. By the time New Zealand would require a whole new referral. Because the person you are in March, I can guarantee you is not the person you'll be in August. You've either done some renovations to yourself or you've gained so much weight like I have done in the last 3 months. But just to answer Dr. Tafa's question, now, if one provider closes the door, we go to the next provider. And I know it's a lot of work on Medicist's end because we're like, okay, that's in Auckland. What about Wellington? What about Christchurch? I'm sure there's somewhere that can get an earlier appointment, and if not, they'll be on standby to see. But I am more pulled out, to a tomato mai. Referral, almost 100%, you delayed it yourself because you had so much other obligations to tend to. Fatima? Oh. Sorry, Fatima, and then Nuat Famamliana.
Whaftaya mo le avanoa, nofo lava I mo whaalongolongo e. O le ele se fesili, na se tua lalo atu tato polo kalama. I le whaamanuianga o tutuila mo manua, I whaamanuianga ne al Medicaid. O nofo ale ia mo mawhawhau, I tangata o si tatu atunu.
Leo te wawa ai atu nei tato au fia nei o nei tai au. Ia, o directors, o tangata wa malama lama o mai mea nei a whapea. Mana ia pe ana mawhai o na au mai ia tangata o si tato atu nuu e whaalongolongo i whaamanuianga nei al Medicaid. E esele le mana ia. The reason I'm saying this is because I do a lot of awareness for our governments. And I hear ia whaafitau ia nei tangata ia le malama. Pia la lo sau noanga ua te a. A malama le tangata i le whaamatalanga o le wingo le poloka lama le Medicaid. There is the problem. They will all understand and follow the procedures and know exactly what to do. But o lo te no fo atu i nei mo o mawhawhau talo o whae i tangato, isi tangato si tatu atu nuu o le o malama. Ai mawhai o na o e le benefit lea, le benefiki lea. E mawhai o na o ala lawai nofo e lato ainga because e le tango lima. Pa wā tangata i e mawhai o na o, ia o tangata o tango lima ma mawhai na o e tali fesili nei a. Nau si tu o lalo i lawa whiunga le sui whaatono. Ma na ia ai whai se tato awareness for our people, even the people in Manua, for tutuila. Ma wha malama le e le winga o le blessing le nei. Wa o mai Amerika, levanga i Amerika Samoa i le Medicaid. And they can take advantage of it. Thank you.
Kei nawa mone tu alano fo i tina. Moni nawa le sau noanga. Since last year's summit, we said that we were going to do outreaches. So far, we were able to do an outreach in Manua. We took the team to Manua, and we were able to the same presentation for them fight. Malama ili tangata nu o motusa. And then while we were there, we were able to register a lot of them for services here on Matioata, on the medical equipment, or in Ato Emana Omia, se Chudo Nama, Oloa, Eva I, Mamefa Pena, but we also have the service on the Manua Medevac. Emacho Tengadu Fatasi Mane, Matanga Duenga Soifua Maloloina. When a patient needs urgent medical care and attention while they're living in Manua, the DOH physician initiates the referral. Initiate the referral in the Medicaid, no, there was Tongina, my Fanatinatia, Yatato Tangata, no, or Motsele Manuatil, or Lisina or Nanga. I'm morning Tananga. Atato Tanga in a map. Majority of us who are in this building, and this was the assumption I told the team last night. I have a feeling of Tangata Umaon Ao Mai in the summit there. They either live in Tualauta area, Daitu area, and Fangaloa area. Because of the central there, they oine o alu umayain information. Information is accessible. Medical care is accessible within these. Atato Wauchiro, either far east, far west, or now, and this is a good analysis because then we know where to target. I more outreach, and I believe to make factono, I messaged officer on my scene of phone. I know what to know yet. On a way for inaleo my money and so no anga fatima, and naleo my on a malamalama, but be an we used to make to tongue. Pe ma mau fo ide ala o wala mana fainanga due ma fainga pa anga MePOS le ala na mai ia Salmon Island Smiles a so no dem faino mai tanga nei and fainta to oi tu ai o ya I live so sani na fa tai mo tu alano nua.
Thank you and good morning everybody. I want to thank the director for putting this whole thing together. So also want to thank former Director Medicaid being here. For this topic that we're discussing, I want to thank my primary care physician, Dr. Early, for always telling me, Motusa, you need to lose weight or you will die early. So today I want to request to my doctor, please just order me a big airplane and send me off island where I can go look for bigger machines. But I do want to, I'm also part of the children with special needs in American Samoa. We have over 400 kids that are integrated into our school system, and sometimes they have no idea what's going on. They need a lot of help, a lot of support, and I do believe only Medicaid insurance can help us deal with that. In regards to speech therapies, PTs, OTs, and all of those, we cannot afford to bring those folks here in American Samoa. Costs over $200. So hopefully we'll be able to work with your office, the director. The name that was given to us was Matilda, and we're going to hound on you, Matilda, so and you can help us maneuver through the very wavy federal system. That's number one. Number two, I hear some of the support being provided for the residents of Manua. Thank you very much for helping us evacuate our folks during emergency. But we do have a clinic that's just about ready to finish, and one of those open space have Medicaid office all over it, but I'm not sure if that's true. So hopefully you folks will consider that to have your office as a branch in Manua. So with that, thank you very much for having us. God bless, and thank you, everybody.
Thank you for being here. Dr. Ed.
Since you're talking about prevention at this conference and the prevalence of diabetes on this island, how can one be eligible for the glucometers to prevent the complications of diabetes? And who is responsible for encouraging patients to get those glucometers?
I think it's a shared responsibility among all the healthcare providers. And I think our panelists, our panel today, consisting of all our medical teams, I think it's not just Medicaid, it's a LBJ job, it's a DOH job, it's all our jobs to advocate for prevention and getting these glucometers for our patients who, because, as you mentioned,
do they have to be on insulin to be eligible for the glucometer, or can they request the glucometer if they're just on oral agents?
For our DME processes, because it is available at MedQuest, so long as your primary physician, whether it's at DOH or LBJ, prescribes this glucometer to you, you are eligible to come to our office with your DME application, and we'll screen. I believe we do have one question that was submitted via the QR code, so we're gonna go ahead and read it. Is there a way Medicaid can expand eligibility so more people with disabilities, especially those not formally employed, can qualify for services? Now, I believe Medicaid, in American Samoa, we don't have an employment requirement. You don't have to work to be eligible for Medicaid. The eligibility that we did mention earlier was, regardless if you're disabled or not with special needs, are you a U.S. national citizen? Are you a child under age of 21? But at this time, we do not have employment requirements similar to Medicaid in the States. Did you want to add, Chile?
If this is referring to the One Big Beautiful Bill Act that requires work requirements for Medicaid, so the territories were actually exempt from a lot of the requirements under that bill, so it's not going to impact our territory. But in turn, because we are not impacted by those requirements, the only thing that remains is that our our federal share stays the same. And then our federal FMAP, which is actually the highest it can be, which is 83%, stays the same. So it should not impact any of our people, no matter whether you're employed or not. You can come in, as long as you're eligible under our Medicaid program, we're here to help.
Oh, testing, thank you. This is great conversation. Thank you so much, everyone. I want to just provide some background. Medicaid has been on the island for 43 years. And when it started with one provider and 35,000 residents that were fully qualified and eligible. That provider was LBJ. Since then, the previous directors prior to me, since I've been in this role a little over a year, have expanded coverage through more providers. So you see it's not just LBJ that is our main provider and DOH, but we have more local providers that are here. And then we've also expanded coverage in New Zealand as well as Hawaii. The thing is, this is a federal program, and anything that we do in Medicaid stems from the state plan. So you can imagine this state plan has been there for 43 years. Any change has to go through amendment and also has to be reviewed by CMS, who's the Center for Medicare and Medicaid Services. So there's a lot of steps that have to take place in order for us to affect change. And when you ask for coverage, when we get the data in, we start to review. Does our current plan cover that? If it doesn't, and there is a need, then we look at ways to how we can cover this service. And so with eligibility as well, eligibility is determined by the federal standards for us because this is a federal program and it is funded by tax dollars of people who work in America. Okay, so I just want to set that understanding so you know that this is probably the most coverage we've had in the existence of Medicaid since we've expanded the providerships here. And this theme now, prevention, really is to help us decrease the burden of off-island referrals. We all know that Scott's job is a really hard job at LBJ, and we have very limited resources, very limited care, specialty care, and abilities there. But that doesn't mean that because we don't have it there, that everyone is gonna get that care off island. We still work on access, but I believe prevention and trying to help our people and ourselves take better care of ourselves so that it doesn't get to this crisis point is the way we need to head right now. The benefits you see are the benefits we have. And we are working with so many community leaders right now, even with NUA saying, expanding with the SPED. We want to partner with you. We want to figure out a way. But please understand, we have a very limited budget that we don't utilize fully because we are required to have a local match. What that means is American Samoa has to come to the table with funding, local funds, in order to draw down the federal funds that are there. And unfortunately, it is insufficient. We do not have enough local match to draw down the millions of dollars of medical federal funding that we have available to us, which is a shame. So that's one thing. If you can talk to your faipule, our senators, to help us generate enough revenue and provide us more local match, that can allow us to get us better access and better care. So we can talk about all this availability of services, but if we don't have the funds to do it, it's very difficult for us to do that. And with regards to veterans, we want to help. You all are eligible as residents, bona fide residents. You are eligible, but we are the payer of last resort, like Deputy said. So we are not going to step in when there is another insurer that's responsible. We will come in on the back end for you. And if you have issues, if you're not 100% covered from the VA, please come talk to us. Help us, let us help you, help us find a solution for you. This is about finding ways to get us better access and also better care, and to also help our doctors at LBJ relieve that burden. I'm the last one because the Q&A is great, but we have another topic that we must move on to, and then we'll have another moment for Q&A. Is that right?
So we were able to gather a beneficiary video, and this video will highlight one of the beneficiaries' experiences with the Medicaid office. So, enjoy.
Hi, my name is Rosalia Cialinga, and my son is Xavier Williatsa, and I'll be talking about our incident that happened back in November of 2024. Xavier was playing with his cousins, and he fell out of our second-story window. And it was hard because I was in the room about 6 feet away, and I couldn't get to him in time before he fell out. So that moment of him falling out the window runs in slow motion. Like, it's a loop in my mind that I can't forget. I rushed out the door, and when I got to him, he briefly gained consciousness. I was hesitant to move him only because of what I was taught through first aid care. But as a mother, I just wanted to hold him and hear his voice and just make sure that he was okay. My son was only 3. And I just kept picturing his little body falling out the window. And I was just praying to God, like, please bless the hands of the medical team. Please bless these doctors. What they're doing right now to help him. He was showing signs of movement. He was screaming, he was responding to pain. So they were saying that's a good sign. And they also informed me that unfortunately the MRI machine was down. So they're gonna look into an off-island referral. They weren't sure whether or not it would be New Zealand or Hawaii. But they just told me hang tight. They're gonna work with Medicaid to get an answer for us. In the meantime, they were gonna put him in an induced coma for 3 days to allow whatever possible injuries to allow it to heal. While waiting for word for approval, there were steps that I needed to take for my son, for us to travel if we were gonna go to New Zealand. I learned that as long as one of your parents was born in American Samoa, you are qualified as a resident. So Xavier's father was born and raised here in American Samoa. That qualified him as a resident. So the transition was smooth, which was fortunate for me because I was already stressed about everything else. So Medicaid really provided for us. I didn't have to worry at all outside of just waiting. Like, it was just waiting. But they stayed in constant communication with me. They eased my anxiety because as a mother, it's hard to just sit still and feel so helpless when your child needs the kind of care that you can't provide. That's hard, but Medicaid was able to step in and just constantly keep me in the loop and say, like, we are working on it. You're most likely gonna be able to go to New Zealand. We'll take care of the transport. You don't have to worry about finances. We will get you there. So that was a big relief for me. There wasn't a moment where I felt lost or abandoned by Medicaid. What I'm most grateful for is that we weren't turned away, because you hear all these horror stories when it comes to medical insurance, Medicaid providers and stuff like that. Like, there's so many people that have different testimonies where medications are expensive and they can't cover it, or surgeries are denied because they can't cover it. So those were in the back of my mind, like, is my son going to be able to get these services and Medicaid provided fully? I didn't have to worry at all. Xavier is doing great. You look at him and you wouldn't even know that he fell out of a second-story window. Like, it's a kind of a running joke in our family. Like, when you meet him, that's his personality. We feel like this is gonna be something he's gonna brag about, something that he's gonna use as a flex, you know, like, oh, did you fall out of a second-story window and walk away with barely anything? Like, he's thriving. It's also inspired me to truly thank God for everything that we have. There have been circumstances in our life right now that kind of shifted our reality, but I'm starting to focus more on the blessings that He has given us, that He has provided for us.
And that leads us straight into our group photo. So if we can have everybody to the front here for the group photo before we serve lunch. Yes, it's already lunchtime. I'm on morning lava. I'm fine as soon. I'm trying to make out of my name. But that's a point. I'm going to ask some more. Yeah, when you need to see if you're too moody or if you're out of the Yes, we can use the stage. Staff, go on.
Everybody wants you. Everybody wants your love. I'd just like to make you mine, all mine. Now, baby, give it up, baby, give it up. Now, baby, give it up, baby, give it up. Everybody sees you. Everybody looks and stares. I'd just like to make you mine, all mine. Now, baby, give it up, baby, give it up. Now, baby, give it up, baby, give it up. Give it up.
Hey, everybody smile and hold.
Everybody wants you. Everybody wants your love. I'd just like to make you mine, all mine.
Squeeze in. Let's smile and hold. And we're all looking at Daniel.
tino ia le pelo fa ni e mautu ala tamano i le lumanai Paano le fatua ualayu Esa sanang na namu ete o sa suau Hoa me sina malalanga e o tua Ola mamaru ia tuma me a
Leo ma fonga o le tawaitai whaatonu, batu le nganga whaatai, I le Alfai Pese ma losi al tātou territory, mai se nawa le sunga taitai, pati, ia ma le loa, o le Alfai Pese I ona tūlanga whaalupe, whaatai, ia wa saunia foi le ofisa, so tau pāsese, ia ai mai se tau mawhasanga, manuia toi fo I atu I whiau mga nuenga, whaatai tēne. We are not done for the day. We have a clinical panel coming right up after our lunch break before our final presentation.
director to, okay. Inviting on stage our panelists, number one, Dr. Audrey Tarr. Round of applause for Dr. Audrey Tarr. Representing the American Samoa Medicaid State Agency, Dr. Annie Fuavai. We also have Ashley Parsons representing MedAssist. And she is also a registered nurse. Representing the Department of Health, Dr. Eminoni Naveno. And finally, our CEO for the LBJ, Dr. Scott Anesi. Okay. And now I'm turning over to Director. They need the mic. Oh, they need a mic. There are two? Oh, there are two mics up here. Thank you. Thank you, everyone. So this is our first panel of the summit. This is our clinical panel. Tomorrow we will have our community panel with, that will be made up of our community members and beneficiaries. So thank you to the panel who's up here. Dr. Annie's already carrying her false card. We're not going to need those cards here, Dr. Annie. But, you know, we talk a lot about prevention, right? But too often we still see patients when it's already a crisis, right? So today's discussion is about understanding why that happens and what needs to change. And so I'm going to ask you a question, and each of you are going to have the opportunity to respond. So we're just going to pass the mics, okay? So our first question, our opening question is, not difficult, but what conditions are you seeing most often that could have been prevented or better managed earlier? What conditions are you seeing most often that could have been prevented or better managed earlier? I'm going to start with our Department of Health doctor, Dr. Aminoni, and we'll just give you maybe a minute or so to respond. Also, audience, get your questions ready. If you need clarification on their responses or have a question that doesn't have anything related to what they said, you can ask it, okay? We have runners down there with mics. Dr. Noveno?
Thank you. Thank you for the question. I'm Dr. Eminoni Noveno. I'm the acting clinical director for the Department of Health. We have the medical director, Dr. Sipilis, here. Unfortunately, the director is not able to make it. What do we actually see at the Department of Health, especially Tafuna Health Center, which is our busiest clinic? We tend to do primary care and some urgent care, really. What we see is mostly chronic, stable conditions. So when I say that, I mean diabetes, uncontrolled diabetes. We see a lot of people coming in with A1Cs about 11 and 12, 14 sometimes. We see uncontrolled hypertensives, people with high blood pressure in the 180 and above systolic blood pressures. We see people that refuse to do dialysis even though their GFR is low. We see chronic, we see a lot of infections, but in terms of NCDs, a few cancers, and then heart disease, congestive heart failures, cardiomyopathies. So it's the usual run-of-the-mill cases that come to our clinic.
Thank you. That's very helpful. Want to pass the mic?
So what I saw most often in the gynecologic population, so taking care of women, were very similar things, but it's part of what we would call a metabolic syndrome that primarily starts from weight. And I know there were conversations earlier about we don't understand what normal weight is for Polynesians, but that's actually well studied. We know what normal weight is, and we know that the weight's causing problems when we see diabetes, hypertension, renal failure, that is a consequence of an unhealthy weight. And that's partly how we define healthy weight is, are you getting the conditions that come from unhealthy weight? It's also related to cancer, and so I'll just comment about one thing unique to women. So when we screen for cancer in women, almost everywhere else in the world, we're most worried about breast cancer, cervical cancer. On the island, the single most common cancer I saw was endometrial or uterine cancer. And it's again directly related to weight. It's an entirely preventable and curable cancer with weight loss. It's also the main reason for infertility. So the weight and the complications that happen with the hormones from that was the main cause of the inability for women to have children who desperately wanted them. And so a lot of the work I ended up doing was around understanding, why do we have this weight? And what would it take to change it? And it's a complicated answer. It's not coming into the doctor for a pill. But it's the challenge that the healthcare system and the government and the policymakers need to address in American Samoa is, why are we here and how do we help move ourselves out of it? Because nobody is there because they want to be there, right? We don't go out and decide, I really want to gain a lot of weight today, I want to have diabetes, I'm going to go do this. But our system makes that the default and it's hard to move from it.
Thank you, Dr. Tara. I think we're all aware that we have a high obesity rate on island, and that's what she was referring to in terms of weight. Sometimes the scales that we utilize don't look like they fit us, but still, this is something that can be better managed earlier for us before we hit crisis. Dr. Annie?
Thank you. I'm going to speak Samoan for the sake of our Samoan speakers. Ole tala whaanoa noa, ole maisuka. Vai so umalava i le official Medicaid. E mai le referral mai LPJ. Pe lua i le tolu o isi vai aso tolu le pa. Ia tātou tangata wa afia ia lātou kufonga. Wa tawaso isi pe tasi le mātou. Ai ole mafua anga lava ole maisuka. Ia ona siaki atu lea le system le LPJ. E le o inuina ia whala au. Ona o isi o lo talitonu le kolengi ma sui le mea tausami. A ole whale tonu na le pia ngai matatou. A pe tolu le wha ia mai le vaiaso. Wha vaiaso se pulu ono. Pe se pulu lua fo. Se pulu lua masina se lau wha. Se lau wha tatou tangata wa apia ia whakonga i tausanga atoa. Ia whaatele atu se pulu tausanga ia wa ova i lunga. O le whaanonoanga na ia i mātou o lo o vai pere ngā duenga i le Department of Health. E whaamole mole. Ia mātou ngā lue whaatas. Se i whai se whainga fōu. O ni awala fōu. E tō sina mai ai ia mawhau o tātou tangata. Ia taumawhai ia whaaleleia le suka i le inuina whala au. Tipi le me lolo me whapena. Vai sina whaamalosi. Se i tau whaititia mai ai lano le tūlanga o le ua iai ia le apianga o poponga o tātou tangata. O le isi mea whaatoa noa ona o le o tausanga o i lātou o loo au mai a lātou referral. Na amata pe ta iono spulu tausanga i au nea le ua iai. Wa amata atua i lua spulu lima, tolu spulu. Ia a o le mafua anga lava o le suka. O le tala whaanoa noa na, so just for my colleagues here, I'm listening to what you have just told them about the uncontrolled diabetes, which is the culprit for all of these diseases. Ia o le whamatalanga atu na ai o le talamoni ma le whaamaoni o na o lea ulo o au mai lava referral vai e so uma ia a o mata lava lea ia o le tala whaanoa atu lea.
Hi everybody, I'm Ashley from MedAssist in New Zealand. We're the New Zealand provider for the Medicaid off-island referrals. And so again, speaking with what my fellow panellists have spoken to, we get obviously a range of different referrals from Medicaid, but the common secondary diagnosis, I suppose, for these patients is uncontrolled diabetes. So how that affects us in our process, I guess, is that it just can make the surgical side of things a little bit harder and things can be a bit more costly to treat. So just obviously optimising those blood sugars and HbA1cs prior to being referred off island is ideal, and you're doing a very good job, Dr. Annie, of trying to be proactive with that response. So, yeah, thank you, Ashley.
Thank you, everyone. I'm not going to talk about the clinical portion, as the good doctors have already talked about that, but everything that they've already referenced, diabetes, hypertension, when all of these are not controlled, which is what they're seeing, there's only one provider up here that sees them, and that's LBJ. And so what we're seeing is not only those that come in with a single non-communicable disease, what we're seeing is an influx of those with multiple non-communicable diseases. And then what happens when you overlay, I believe American Samoa is currently in a dengue outbreak, an RSV outbreak, a flu outbreak, and a leptospirosis outbreak. What happens when you overlay all of these things that are circulating onto an already complicated situation with uncontrolled NCDs? You get to wait in the ER for 12 hours. That's what you get. People wonder why care is difficult and wonder why these wait times keep growing, because the management of 10 different things is difficult. To come in and manage your cough is one thing, but if we're managing also your renal functions, your sugar levels, your heart, all of these things get exacerbated, which puts a high burden on not only the current medical situation, but also on society. So what we're seeing that could be preventable is a number of things. Would they have been in the ER or in a clinic if they didn't get the flu? Probably. But also that means they're not seeing Dr. Eminoni or his providers for things that they could be managing as well. So I think, it's not one thing that we're seeing. The issue that we're having is that it's very complex because we're seeing a multitude of things.
Thank you, CEO. So where are we missing opportunities to intervene earlier? Does anyone want to take that question?
Or maybe why do patients wait until conditions are so severe to be seen? Pass the mic, please.
I think it comes down to this concept of a medical home. So we assume the patient knows before they feel bad that they should come into us for care. And they don't know until they feel bad, until we're at crisis, until they're all the way down the river almost drowning, they don't know they need to come in. And so it's the medical system that needs to own the care of that patient. We need to set up a system where they have a primary care provider and nurses that monitor and reach out to them and say, your last blood sugar was not good. We haven't seen you for 2 months. How are you doing? Let's see your numbers. Let's help. It requires a system where they have a home, and that home follows up and case manages their challenges. Now, people have their free agency and they may still not choose to come in, but we have to own the responsibility for helping them come in, inviting them in, providing a place for them to come into. They need to know where they call when they have a question or a problem, and we have to bring that care to them where they are, or figure out a system that transports them to where they need to be. And we have to provide the care at a time that they can come and get it. If they can't get time off work, having our only open hours during the time when they are at work is not going to accomplish the prevention. And so it's, you know, that sounds like a big, huge thing, but if simply every patient on the island knew who their primary care provider was, who they called if they had a problem, and knew they were going to hear back from that office with the next step, we would start to provide a system wherein which they could access care and where someone watched out for them before they got to crisis.
So, thank you, Dr. Tar. So, in your keynote, you mentioned that as doctors or clinicians, when our patients fail, we fail. And it seems like the onus, you're putting a lot on the clinician, but what about the patient? Don't they have some responsibility or accountability in this?
It's an interesting concept, yes, but I'll put in perspective, the last system that I worked in, they paid me based on how well my patients did, right? If my patients had poorer outcomes than the average clinician doing the same work, I was going to be paid less than those who had excellent outcomes. And until we place in some very strong incentives for change, change doesn't happen, right? And you say, well, that's not fair. How can you hold the doctor accountable for what the patient does? You know, the patient has their own, that's absolutely true. But until it's hard for me to not do the right thing, right? Until it's painful for me to not keep working and finding a solution that's going to make healthcare improve for that patient, what am I going to do? I'm going to survive. I'm going to keep pulling them out of the water at the end of the river because I have no incentive to change. We have to make it painful enough. All of us, right? We have to, it's a system, it's not just on one person, but we have to make it painful enough to do the wrong thing, right, to affect the change we want. And I will reiterate, change is painful and hard, but we will always get what we incentivize for. So until we change our model of compensation, of funding, of what we value, we're going to keep getting what we don't want. And yes, patients do a certain point, but we're not going to solve everyone, but it's amazing when you change the incentive how much harder a system works, a team works, and how successful that is for patients. It works. It works in every system that's ever tried it. And it can work here, but it's a painful change process.
Would you like to add anything, the doctors on the panel, to the incentives that we need or lack, or what incentivizes you to go to work every day? I guess, Dr. Eminoni, I don't want to put you on the spot like that, but it seems that without incentive, a lot of people aren't motivated to move in any industry or in any capacity. So I'd love to hear, I don't want to go too far off the topic, but this does seem like an important topic to discuss.
What incentivizes me to go to work? To pay my bills, literally like everybody else. That's the bottom line, really. But on top of that, you know, it was always my dream to care and look after people. I remember when I was in fourth form back home, and I wrote down in our career class, what do you want to do when you grow up? I wanted to help people, and my teacher laughed. They thought that was a very simplistic answer, but that really is why I got into this career. So if we talk about incentivizing, it's a dream in the Pacific Islands. We really love to incentivize, you know, what the doctors do, but the fact of the matter is there are constraints to that, like funding constraints. There's people, you know, even though we want to look after NCDs only, we are so short-staffed that there's a lot of demands placed on us to see everything and everybody and do everything apart from just clinical work. But I'd like to go back to talk about the gaps. When we talk about the gaps, when we want to address the root causes, I think we really need to go back to what NCD is and what we keep calling it lifestyle disease. What does that really mean? It means knowing how to live. So if we talk about that, it is a system issue. So if we talk about a system issues, doctors, to be brutally honest, were not taught wellness and lifestyle. We're basically taught disease syndromes and treatment. So whatever we know about wellness right now is basically based off of our own readings. So what I'd like to suggest is maybe this system, the downstream system, is not built for wellness. Maybe we can build parallel systems. So when we talk about parallel systems, they are not competitive, but they're supportive. So instead of an NCD department, maybe we can have a wellness department that can really teach people how to live. So when I say teach people how to live, you've got to know the basics of what it is that governs nutrition. So when we talk about nutrition, the type of foods to eat, the regularity of when to eat it, how many hours apart, how to chew your food, how to mix foods, when to drink water and not mix it with while you're eating. So it's the practicality of it. We were not taught how to live a healthy life. So if we talk about standards and where the gaps are, we can go back. All of us, most of us are Christians. Our foundation is the Bible. We can go to Genesis 1:29. It talks about the quality of foods. So we have to fill in the gaps and teach our people how to live, basically at home. And then that can be formalized in the curriculum in the schools from a young age. And then the doctors can also be taught on those rules. Like, for example, there is a lifestyle system called New Start, for those of you who are aware, that addresses everything that you need to know to live a healthy life. Like, New Start is an acronym for nutrition, exercise, water, sunlight, temperance, air, rest. So those are actually the laws that govern our living. So if I know the laws on how to live and be healthy, I keep them, I am healthy. And if I break them, I get disease or sickness. So maybe the system is not built for wellness. Maybe we need to build a parallel system that will support the work of the DOH, because otherwise we'll be here again every year. I was here last year, I'm here again this year. We keep talking about the same broken system. So maybe the system is not broken. Maybe it's doing exactly what it's supposed to do, wait for sick people. Maybe we need to build a better system that will make sure we empower people with knowledge, we motivate to change, and then we build the systems around them that will look at what are their priorities. Maybe their priority is not health because they're struggling to live day to day. So get the Department of Commerce to look after their welfare, teach them knowledge on how to make money, and then we can talk about health later. So those are the gaps that I think will help us better manage this crisis. Thank you, Dr. Forby.
Thank you, Dr. Naveno. Appreciate that.
That was a long speech, and he has all the answers to the problems here. So are you implementing those? No?
We're working on it, right, Naveno?
Anyway, just to add on, I know we have a broken system. We all know that. But as a Samoan, kalasa'oa, we need to change our attitude. You don't feel any pain. Ale ay semeti nga ka nga kasamoa. Magpade anwan falmai. E feel for mai fayakway o ke suka. E pawale kala kene lopola me feme o ke suka de semeki nga. So that's the attitude of a Samoan. O longa dua e feel mo fie. You give them tablets to take, they'll probably take it for 3 months. And then after that, they're tired of it. And then they'll stop taking. Lona tolu. e o I fufo Samoa. Ma ka ui fole e le fufo. E kanga ka suka wa marosi langa fufo. And then this vicious cycle just go on and on. So it's multifactorial. I hate to say that. One is the system. I'm speaking on behalf of my relatives in the States. In the United States, they have excellent system, excellent healthcare. But they're still dying of diabetes. Why? Because of our attitude as Samoans. They don't want to take tablets. They don't want to go to the hospital because they don't feel any pain. And plus, they continue to get these traditional medicine from home. So that's my take into this. But I think the bulk of the work is Dr. Emanoni. They're the prevention side. Thank you.
Thank you. I think it's great to have clinical providers, and then I think I'm the only administrator on the panel. But when you hear it's a broken system, what do we mean? Does anybody in the room know what's broken? Why it's broken? Well, the reason it's broken is because this is a system that not only we asked for, but it's one that we accepted. What do I mean by that way? Our healthcare is largely predicated on what's being funded. So you just heard Dr. Emanoni say that public health would love to do other things, but they only do primary care. Why? Because that's all they're funded for. The federal government funds them to see primary care patients. Anything above that, what happens? They send them to LBJ. Why are their nurses not out in the community? Why are public health programs not in the schools? Because they're not being funded for it. So we basically accepted that the only form of funding that we're going to use on healthcare on this island is federal funding, which means whatever the federal priorities are going to be what's funded in the territory. So the question that we first asked here was, why does Medicaid and Medicare matter? Because that's all we've got. What's the alternative here? Nothing. So we're predicated on federal funds, but we're funded based on other people's priorities. So the system is broken because we've accepted that, yes, we're going to take this money and this is the only service we're going to be able to provide, regardless of whether that's the service that our population needs, because we have to pay bills and these are the incentives for us. So I just wanted to say why the system is broken is because the federal programs that fund our healthcare system are very, very specific. And so now, how do we fix that? We fix that by partnering together to try and assess where the gaps are and how we can share our resources to now fill in all of these gaps. And that's where we need ASG, that's where we need all of you folks to start looking at all of these gaps here and how we're going to fix that internally. But at the end of the day, not everything's going to get funded or not everything's going to be able to be done. So I think I also don't like to say that we need more resources and we need more of this, because sometimes we're not using the resources that we have as efficiently as we can be. So that's where I think coming together as a panel and having discussions like this allows us to essentially see the gaps, and maybe the family healthcare system is a way to go, and how do we fund that? How do we join together and now figure out how we can move that forward?
Thank you, CEO. That was great insight. It's true, we are predicated on federal funding here. And because of that, it's important for each of us to take it upon ourselves to take care of ourselves. You know, I think there is this misconception that LBJ needs to be responsible for my health care, or DOH needs to be responsible for how I feel today. But in all honesty, it starts with us, each of us, informing ourselves, getting educated, and making sure that we are aware of our circumstances and not waiting till something is wrong. Prevention is a stage of preparation, right? We all have one body to live in, and each of us have been given that body, we believe by God, And what we do with that body is up to us, the choices we make, what we take into our mouths to ingest, what we expose ourselves to in the environment, that all comes into play. And you've heard here this morning with this panel, you've got representation from LBJ, you have the CEO from LBJ, you have a doctor from the Department of Health, you have our clinical director, but also a former CMO from LBJ. You have one of our providers here who's an RN that manages the off-island referral, and then you also have a former medical missionary who worked with our women. And so this panel is going to be here to field some of your questions too, but to help us get motivated and inspired to start taking better care of our own health. Okay? I wanted to know, maybe we answered this, but what would help you as clinicians intervene earlier in the phase? Because you've already said that assessing the gaps is one thing, but what would you say would help you intervene earlier?
So I can speak to some of the constraints I experienced while here compared to what I had at home. And so I was not a single lone ship taking care of patients at home. There was a whole team around me that looked at any patient who was due for a pap smear and hadn't been in. That nurse case manager was reaching out to that patient and reminding them to come in. Or if they had a mammogram ordered and they had not yet completed their mammogram, they would call them and remind them, or email them, or message them, or they would communicate with them to come in. And that team worked to get together. So one of the challenges was the team was not as robust as different systems I've worked in, and that means that in many cases our providers on the island are kind of functioning as lone ships, and the ships are sinking, right? Because they need help and support to do that outreach, make those changes. Otherwise, all they do is go and see the next patient in line because there's no light at the end of that tunnel.
Okay, I would like to open the floor for any questions that you have regarding what we've discussed. I have a closing question after we open the floor to each of you. This is your time to speak to our clinicians. We have the CEO of LBJ, like I said, we have a representative from DOH. But really, this is your time to ask questions, those burning questions that you had as you were sitting there listening to ways of prevention. Because I asked them why they think patients wait until conditions become severe to come and see them, but maybe you have a different reason. Maybe you can't come see them for whatever reason, but I'd love to hear it. So any questions out there? Dr. Early. Can you use that mic, please? Right behind you.
Part of our responsibilities as physicians is to educate our patients. Our patients are not getting educated. We are prescribing medications and sending them out the door without an understanding of why they're taking the medication, what their disease process is. We blame our culture. Well, if we look at, just look at the pictures on Kvzk when they show our ancestors back in the 50s. You could not find an obese Matai in those pictures. But you look today, our kids are obese. We need to educate the parents. We need to educate our kids about what they're doing with all the food, processed foods that we are consuming. It's a crime to see kids walking to school at 7:30 in the morning with bongos and a Coke in hand or a Pepsi in hand. Our legislatures should legislate against food items that are being brought in and you can't read the labels. You don't know what's on there. It's our responsibility of physicians to take the time to educate them and to teach them about diabetes. It doesn't cause symptoms, as Dr. Fubai said, but their elevated blood sugar, while it may not be producing symptoms, is damaging their eyes, damaging their kidneys, damaging the nerves in their feet, causing neuropathy. We need to educate ourselves that we need a paradigm shift in the way that we approach diabetes. We talk about diabetes being a disease that causes increased thirst, increased urination. Yeah, that's true of type 1 diabetes where there's no insulin, but with type 1. Type 2, our kidneys change, so we don't spill as much sugar the higher our glucose levels get. So we tend to hang on to that glucose for a long time and don't spill it until it's 350, 400 before you have symptoms. People need to understand that. We need to change the medications that we're using to treat diabetes. The sulfonylureas that we're using today shouldn't be the first line of treatment. Yeah, it works for a little bit, but the longer you use it, the more resistant. Diabetes type 2 is a disease of insulin resistance. So giving them more insulin may help, but the more insulin you get, the more resistant you get, and the more difficult it is to managing. We need to look at providing better care for our patients, but educating them. I think we need to be moving our physicians into the communities rather than having them sit at LBJ Hospital where it's just packed. Who wants to go to LBJ and fight to find parking? We should have our clinics out in the communities where people can have easy access and easy care to those out in the community rather than all fight to go to LBJ.
Thank you, Dr. Early. Dr. Early serves as a physician at the VA, and thank you for those words of wisdom. Dr. Sapili.
Thank you very much. It's not a question, I just want to add on a brief comment into our discussion. I'm hearing outreach a lot, which is very appropriate. And I just want to say that Department of Health is currently starting to implement this initiative with the NCD where we go out to the community. And this is already started with the Afono village. It's called Afono Manuia. It's not because I'm from Afono. It's because we're starting from the underserved, inaccessible areas of the community of the territory. And so we go out with different programs, which includes tobacco, diabetes, MCH, behavioral health, cancer, even environmental health services, and including the vet. Because right now with this laptop coming up, we need to inform the public about what's causing this infectious disease. And of course, we all understand that we need to educate the public. And then we come here, this is very great that we have this summit every year by the Medicaid to better inform the public. But we also need to go out to the community when they're unable to come in because of, first of all, maybe transportation. Second, maybe they couldn't afford. Third, maybe they're afraid to see the doctor. Fourth, maybe they don't really care much. Sorry to say that. But we need to get to their level, and this is why I think out in the community is very important. Prevention is very important, of course. We all understand that. We need to get to the level where when patients and people in the community are well, and teach them before they get sick. Because when they do get sick at that level, it's already late to do something. And when they do present to the hospital, that's where, we have to use the resources, the limited resources that we have on island to care for these people. And it's a shared responsibility when it comes to prevention. We do our part, we go out, get immunization, we go out, teach, we go out, do whatever. But they also need to help us by, you know, keeping them in good, healthy lifestyle and trying to do what we're trying to advise them to do. So I think it is a really shared responsibility. And we need to go out and explain all this in Samoan to the people, because I know a lot of them may not understand, especially when it comes to Medicaid services and whatnot. So that's my little share into our discussion today. Thank you very much.
Thank you, Dr. Stevie. I appreciate those words. We have a question? Okay.
I'm going to throw the discussion just a little bit on the left side. I had a daycare for 4 years. It was quite new to me. I've taught at the college, at the university, but now I'm dealing with kids that are 3-4 years old before they get into kindergarten. Anyway, the school lunch provides each daycare some assistance so that the food offered in daycare is as balanced as possible. So I'm telling the cooks in my daycare, okay, prepare the oatmeal and get the toast and the fruits. Meanwhile, the kids are crying, and the first thing the mom pulls out of the bag is a bag of chips and juice. And I thought to myself, oh my goodness. I could see it at lunch. I can wait. First thing in the morning, the kids are giving chips and some kind of very sweet juice. So that's their breakfast. The point I'm trying to make is, with all the Asian stores now available just by walk, and our people are eligible for food stamps, that gives them the ability to go to the store, not go in the backyard to grow taro and papaya. Go in the store and buy what is most convenient. We are facing a culture of convenience. Rather than work out in your little famua to grow your food, it's easier to go to the store and buy everything that's canned or in, which is very high in sugar or high in salt. That's part of the education that we need. And I'm not saying anything derogatory about the Asian stores. They're providing us a great service. It's a matter of choice. And our people now have the ability to buy, in addition to what little money they make, with food stamp, which is, I wish the food stamp people would educate our people. Use the money to buy healthy food. So that's one of the things that we have to deal with, is now we're facing the not only health issues, but a change of our cultural habits. Our people are not using the land to grow good food. We're at the market buying all the junk food. High red meat with lots of fat. Okay, I have to tell myself that when I go to the store. But anyway, just to throw out, so that is part of the problem as I see it. Looking at from an educator's point of view, this change which our people don't realize. They're happy to get the food stamp, but they don't know that the convenience is also adding to the health issue. You will have about that.
Thank you. This is definitely a shared responsibility for all of us. I'm hearing we need to teach, we need to educate, this is the same thing we've heard year and year again, but sometimes it doesn't really affect you until it happens to you, to where you're in the hospital or a loved one is in the hospital, and even at that point, changes aren't made that are necessary, but that didn't take us far off. It's all related, so thank you. We're going to take a couple more questions. We have this wonderful panel here to field questions, and then we're going to move on.
Thank you for the opportunity. I want to throw this back to you guys. How do we follow prevention when most of the doctors and nurses that I go to the hospital, which is once a year or rarely, looks like they need medical attention from me? You know, I'm blind first question that comes to mind is, when people come up, it's like, Kalofaya, are you diabetic? No, I have RP, retinitis pigmentosa. I was born with it. But I'm more healthier than most of the people that are preaching stay healthy and live healthy, And sometimes I wonder, like, where are government leaders? I mean, you look at them, I look at them, they're way overweight, And the doctors, nurses, I mean, God bless them, God bless their heart. We don't know their personal struggles, but sometimes I feel like giving them the blood test. Thank you.
So we always run into that problem of it's very difficult to preach if you don't practice what you preach. But I'm going to take it a step further. We've talked about education extensively, and we need to start asking more questions. Why is the education there? I don't think it's just a problem of people knowing that they should exercise. I see a lot of exercise on the island. It's not just an issue of knowing they should eat different things. Why, if they know they need to change the eating, is it not happening? Why do they not follow the education we give? We need to ask some painful questions. Do they not trust us? Like, do they feel like we're telling them in a way they can't understand? Like, is the trust in the system so broken we have to look at how we're going to do this education differently, how to restore that trust? So we come to the simple answer of, I'm going to preach, right? And then there's all the problems beyond it. And there is good study in medicine and the science of change that the least effective method of change is to tell someone what to do, right? Flogging them with more instructions to lose weight is not going to help with the weight loss. We really have to be willing to get into the weeds with them, to ask where their barriers are, why they're not doing it, and acknowledge if they don't trust the messenger. How do we restore faith and trust in the preacher, and that it's a process we're all going to do together, because none of us are perfect. I preach far more than I practice. If I did everything I told my patients to do, I'd be extraordinarily healthy.
Thank you.
That's a very valid point, and I'd like to just say that that's an inside joke for most medical professionals, is we know most of us are unhealthy, including me. I'm working on my weight, by the way. But also, at the end of the day, sometimes, us having these conditions or these difficulties as well makes us relatable, because we're in the same settings as well. We also have our own struggles. Like, I am addicted to food, especially wheat, and that was due to trauma that I got when I was really young, and I'm working through that. So we also have problems with health-seeking behavior, just like you do. But somebody's got to do the job. We learned, a little bit more than the average person has done, and we'd like to think we know a little bit more, than the lay people. So it is a fact that we also have our own medical conditions to fight with, but, we have something to offer the community. We'd like, to think that we can offer something to the community. But on the point of why is it that sometimes our priority might not be the priority of the average person? So when I say that, I mean, in this setting, in my work setting, my priority is health. So I preach about health. But when I go home after work, it is not necessarily, health is not necessarily the top 3 of my priorities. When I'm at home, I'm just another human. I'm looking for laughter, I engage in behavior that sometimes is not healthy because I'm trying to decompress. So coming back to the notion of patient-centered care, we've got to allow the patient to tell us what their priorities are, rather than us telling them what they need to prioritize. So we come to the point of, if we look at this room, we're talking about health here, we are of a certain socioeconomic status. But the average, the majority of the people that we serve are a little bit lower, I'd like to think, socioeconomic status than us. So their priority definitely, in my experience, now I'm not talking about the Samoan culture, I'm talking more about, you know, in my experience in Fiji, and 9 years here, which is not a long time. Dr. Eddie would be able to talk more about that. Their priority might not be health. Their priority might be the church obligation, the falaglave, the furniture at home. So I think if we ask them what their priorities are and help them direct them to the help that they need to satisfy that first priority first, then they can come to maybe health would be their third priority, right? And then we need to build around that. So we encourage them to satisfy their priorities. If their priority is making money to satisfy their daily needs, maybe talk to them. If you don't know economics, maybe refer them to the relevant authority and then tell them, come back to me when you got that sorted. So I'm going back to sometimes we try to be authoritative in telling them, you need to do this. We come back to the point that Dr. Ta made. Instead of telling you what to do, maybe I need to listen more as a provider. And you tell me, after I'm done with what I need to do for the welfare of me and my family, then I'm going to come to you, and that maybe the patient or the person will be a little bit more receptive to the information or the advice that you're going to give. Dr. Forvai.
I cannot say any more. He said it all. So.
Thank you. Anyone else want to add to this? Thank you for that question. I think it's, you know, we are all human beings, right? And we are all under a lot of different stresses and pressures in our lives. Nobody really knows, but we can do a lot less with judgment, I think, on this island. And if you think about our physicians and clinicians and you've heard of all of the limitations and constraints they work under, you can imagine the stress and pressure that they're under that affects their own health. But just like each of us, our vessel, this vessel, only operates on the type of health that we have. And I want to thank our clinicians for their service and their sacrifice in helping us be better, healthier people. So thank you for that. In closing, you know, last year when we were here, we talked about access, improving access to healthcare. And in that year, we have done that. Our Medicaid agency, in partnership with LBJ and also with DOH, we have expanded our providership. We now have more providers in Hawaii. And we also have expanded our local providership here on island. We also have a clinical director that has access to LBJ's records. We're having conversations, and we also developed a standard of operating procedures with the Department of Health for the medevac process. And all of these conversations stemmed from last year's panel. And so I am grateful that we are having these discussions today. And in closing, you know, I would like to ask our panel, what is one practical change we can make in the next year to reduce preventable chronic disease? Doesn't have to be elaborate, just something that our listeners, our audience can take home. What is one practical change we can make in the next year to reduce preventable chronic disease? Because what is stated here on this panel actually informs my agency on what we need to work on. And hopefully next year, we'll have improved our prevention efforts. So give that some thought, and whoever's ready, please share. Oh, yes, you have a question? Yes.
Esther, there's a...
No, it's not a question. Before that question is answered, I wanted to comment on something that Dr. Tar brought up, and I want to thank you so much for your comment. You said that you didn't want to be paid for the number of patients that you put on your record that you've seen and the possibility that you have saved or healed, which would not be true. Thank you so much, because it's important that as medical physicians, I know that you had done a pledge. There is a pledge that most physicians do and say in order to take care of the public. So thank you very much, Dr. Tar, for that. And the other thing that I wanted to bring out was the information that is given out, that medical information that should be given out by every medical office to everyone on the island should be that everyone that your secretaries or whomever that works in your office should be able to give all this type of information to the people that call on them or come in to say. Because first of all, let me introduce myself and my partner here. Our office is, it's the first time this office has been opened up. It's the Constituent Services Office. And I am Esther Pietro, and this is Lupe Ponopo, and our director is Tiso Skelton. And in our office is like the last resort that the community come to when the community has gone as far as they could go and they still have not been satisfied. That's when they come to us, and that's where we take them through the procedures that was all mentioned in the beginning. So this way, it was similar to what Dr. Early says, for the medical staff go out to as far as whatever the farthest of our villages to go to, because a lot of it is because, number one, medically, a lot of these people cannot come in, and the other one is financially, they don't have the money to jump on the bus and also with their medical condition to climb on that bus or get a taxi to come to the hospital, whatever medical clinic that they're supposed to. The other thing too, as Dr. Tar pointed out, is that I recall that also with the breast cancer office, they call out, they do call out, and I was part of that program. They call out to make sure, to find out if you can make it to these appointments. That was really wonderful, and I really believe in that. So this is the connection that you, Dr. Tar, and your people of your office has provided, and I commend you for that. Thank you so much.
Thank you, Esther. Appreciate that. Maybe just some final remarks from each of you if you are still noodling over that question that I shared.
I struggled with the question because you asked for 1 year, and so I want to make sure I scaled it down.
You don't have the time.
So if we're talking about something that would happen in the next year, I learned well while I was on the island that I didn't know as much as I thought I knew, right? The more we learn, the more we know we don't know. And I think to inform better the changes, we have to ask the people in a safe enough way across a broad enough demographic mix from, the wealthy to not, to one end of the island to the other, to the Manua Islands. We have to ask the question to inform us, and we have to ask it in a way that they feel comfortable to answer. So I saw that struggle constantly when I first came. I would ask the question, and women wouldn't answer until I pushed, went around this. I had to give a safe place to answer the question. So I think we need to answer the question, ask the question, We need to give a safe place to answer the question of what they need to improve their health, and that needs to inform us. If you'd given me 2 or 3 years, I would have told you we need to take and design where there's primary care physician and every patient on the island is assigned to a primary care physician and knows who their doctor is, and their doctor knows who their patients are, and we start holding accountable the outcomes for each panel of patients. But that's not realistic in this next year.
Well, I think that first response is trajectory to get to that next one. So thank you for that.
Right, I'll sum this up in 2 ways. One, on a personal level, for you individually, I just want to remind people that you can reverse your biological age, not your chronological age, by changing your lifestyle. So literally, you can become young again in the body and do the things that you used to do when you were younger if you change your lifestyle. But start with one thing. Don't try and do everything all at once. And then maybe for Medicaid, I just came back from Fiji. We opened our first wellness center in Fiji where you do lifestyle consulting on the top, and then you go straight down to juice therapy on one side and plant-based therapy on the other, basically buying foods and drinking juice to be healthy. So on Medicaid level, I'd like to suggest that maybe Medicaid have covered services for wellness, not NCD. So when I say covered services for wellness, have groups of people maybe do cooking demonstration classes and have that covered on healthy foods. Have people do body weight exercises and have that covered. Maybe that can lump in as a package for primary care. I don't know how that will work out. If we put the money where our focus is, then I think that'll encourage the providers as well as the patients to do more of the same. And maybe anybody in the audience would be, make a business out of wellness. You open a lifestyle center, and that could make money for you and also have an impact for the community. Thank you.
Thank you, Doctor.
Just to add on a little, I think we have the answers. Go lover, and we should start within our families, going outwards. Like other speakers have mentioned, it is when public health. We can come up with all the good ideas, but I believe this community have the answers. And like Dr. Early said, we just keep on pushing and educating our people. Therefore, my new generation, I think it's time for us to educate the younger generations. But we do have the answers. Only me, I love her. Mal de fa maoni lava I talabai mal inu ina fala au. Aptai.
I think from a medicist perspective, optimizing, chronic conditions prior to being referred to medicist will lead to better outcomes off island. So that's what we want for your patients.
I think in a year, if we're trying to prevent something, I think too often we get really lofty with our goals and then we underachieve. If you're thinking about lowering prevalence of diabetes and, as your healthcare gets better and the physicians get better at treating people, they live longer, which means your prevalence goes up as people live longer and people continue to get diabetes. So I think what we really need to do is we really need to sit down and have more conversations. I can honestly say that for many of you in the room, I haven't seen you since last year. Now, if we're all in the healthcare business, what that means is we're continuing to be siloed in our delivery of the healthcare system. And then we get together in health summits here and we discuss about healthcare and bring about insights that are really, really great insights. But then they lead kind of nowhere because then as the year goes by, we go back to our priorities and our daily jobs. I do feel that if we're thinking about what are we going to accomplish to prevent something for the next year, for one, I think we need to decide for that together, and then we need to start setting these goals so that maybe year after year, we can now hold ourselves accountable to say, well, what have we done this year? What are we going to do next year and the year after that? And then we can start to have some type of metrics. But for me, my main goal is to continue the discussions to try and break down the silos and have these discussions with the Department of Health and Dr. Early at the VA, but to come together as the healthcare providers and actually have one main goal that we can all move towards. Thank you.
Thank you, CEO. Oh, do you have a question or comment?
I don't know if it's a comment or it's just an encouragement from my part. 6 years ago, we were healthy kids because two mama came to villages. Anyone that's over 60, 70 over here will understand that the public health nurses would go out to villages. But my answer, to answer that question that I had in my mind was Dr. Anesi said that the federal funds does not cover that anymore. So I don't know the legality and whatnot of that part. But anyway, I would like to leave here and share something that probably would help one or two. Because 12 years ago, well, actually, I'll say, I hardly go to see a doctor growing up. I'm 76. So, let's not be ashamed of our age, okay? Because we're all getting up there. But anyway, I hardly go, but, growing up here, had 7 children over here, and she delivered my last baby, Dr. Kvzk. But anyway, I hardly go see a doctor because we do not eat bongos and, we eat popo, oisi, whatever is on the land. So I know this day and age, the other generation, they're having all these bongos and all these things that are so unhealthy. My point is, it's up to me. Listen to your body, Do you feel sick? Yeah. And don't just try to sweep it under the rug. The other thing that I know, that we should not be afraid or ashamed to say that we are sick. That's another attitude of nagsamo. Wow. And so what? There is nothing new under the sun. Everyone gets sick. There's only one body, like you said, and only one life to live. Listen to the doctors. They're being trained and educated for it. Listen to them. But it's really up to me. So for 12 years ago, I finally, my children told me, Mom, Hawaii, the physician. I said, why? And they go, because you're getting, so I went, 2013, 14. So that's when the doctor told me, yeah, but I pre-diabetic, wait, blood pressure, hypertension. There's 3 of them. Oh, and the cholesterol. Okay, I've heard of these things, and I thought, okay, how old I was then? I was 63. And I faithfully took metformin, and, all those cholesterol pills and lisinopril up until now. But for the first year, second year, I faithfully took it. And then I realized, well, along with prayers, that's my top priority. I could take care of myself. It's such a boring life without ice cream, because I love ice cream. And I just decided, okay, out. I'm not gonna eat it, not every month, not twice a month. In fact, I just had my first ice cream cone 2 days ago, for a long time. I may eat a couple of spoons from my kids' bowls, but you know, no cones, no bowls. Like I said, it's boring, but it's healthy. It keeps me, you know, live another day. So I just want to share this. If it helps someone, hey, let's do it. So anyway, my children are telling me, Mom, you look good. Yeah. Yeah, because I tell la furia tato, yeah, Malaysiano, tatalo, dua tato tu, boleh tu tilo, malanganga. It's not good to have a healthy body and sick ako langanga. You gotta balance it or higher ako the spiritual side of tamata. I believe in that, and I know everyone has their own tatonuma, but this is what I want to share. If it helps someone, don't be ashamed if we're diagnosed with whatnot. Just follow lo for my. Yeah, Savali. I don't have to go to the gym, I can't afford it. I work a lot at home, up, down the stairs, up, down, outside, you know, just be practical. That's my sharing.
Thank you. Thank you so much. So we've heard a lot of great insight through this panel. You know, our theme is strengthening health resilient American Samoa through prevention, but I really feel we're at a stage where we should be building it because we don't have an existing resilient health situation for us right now. There are many of us who are very ill. We have a lot of sick people on our island that need help, that are in crisis, and we really want to try to prevent that by having these conversations. CEO and SE had alluded to keep continuing these conversations, and we are. You know, the governor has made healthcare a priority. He has created a task force that many of the key stakeholders are on. Our executive advisor, Bethany Toilupe, DOH director, CEO of LBJ, myself, and some others are on this task force, really trying to find solutions for us. And so we can't do it alone. Like they have said, this is a collaborative effort. We all need to work together and to make American Samoa healthy again. I wanted to thank our panelists. Can we give them a round of applause? And if you have a burning question that you didn't want to ask, please put it in the chat, or you can see them after the conference. But we are almost to the finish line today, and I'm going to turn the time back over to my team. Don't forget, we have one more day of the summit and another community panel for us tomorrow. So thank you, panelists. Appreciate your willingness to share. Can we get a picture of our panelists?
Okay, this is the final presentation of the day. How about we give it up for our panelists one more time? And I will be speaking about policy and planning. And I know this entire day we've been talking about how unique and different the Medicaid program is here in American Samoa. And this presentation will explain why. Why Medicaid in American Samoa is the way it is, why we do the services this way, and what are some of the federal limitations that the federal government has on our local Medicaid office here in American Samoa. So, to start off, we're going to talk about the 1902J waiver that American Samoa Medicaid currently works under. So under the Title 1902J Medicaid waiver, this waiver basically allows room for the Medicaid office to basically be creative in the way we approach Medicaid. Being remote from mainland US and also the other territories, we are not just remotely positioned geographically, but we also have limitations with local funding. And so the 1902J waiver basically gives the American Samoa Medicaid office room to do whatever it wants. Do whatever we think works for our people. American Samoa operates its Medicaid program on a broad section, as I mentioned. And this is basically to fit the territory's unique single hospital fee-for-service system. This waiver exempts American Samoa from most Medicaid requirements, except for the three that are listed. We still have to be compliant with FMAP, Federal Medicaid Assistance percentages. We are unable to remove the funding caps on our fundings. And also, federal Medicaid medical assistance payments may only be made for amounts expended for care and services described in the number paragraph of Section 1905. So, although we are given room to be creative in the way FIA Chacho Procalame America Samoa, this 1902J waiver also gives us allowance to operate under what we call presumptive eligibility. Now, and for short, we call it the PE system. Yeah, if you are familiar with Medicaid systems in the US, they all operate under IE, or individual enrollments. Enrollments there are at Watu. They would take your IDs, your employment. They would dig into your finances and to see if you are eligible for Medicaid. And that all states in the US, all 50 states, they operate under IE. Now, Tato Navay America Samoa, but the territorial CNMI, we operate under PE. Ona or Tulang or the Tato population. And this PE system works for us. Now, I know in the past we were looking into exploring what it would look like if American Samoa moved to individual enrollment. But after some feasibility studies, or the Whaingatau Tato on the move into IE, because we only have LBJ as our main hospital provider. And so, for those reasons and many other reasons, they allow Tato to operate not only or the PE. Now, what PE is, presumptive eligibility basically means everyone in the territory is presumed eligible. If you go to LBJ, if I know Talavai, we actually the ER, everybody who goes through LBJ, ER, or the Okavai Lado de Procalame Medicaid. Why? Because everybody is presumed eligible. Ia, o le tūlanga e winga ese fo i tātou prokalame na Medicaid I nei Amerika Samoa. Ono tūlanga tātou population. Because we do not follow immigration laws set by the U.S., e lava tātou tūla fono immigration whaalo toi whale. We control our borders and we control our immigration laws. O le winga whamatalanga, so tēnā tātou tangata ainga. We have a lot of family members, relatives who travel from independent state Samoa and who are living here with us, have been living here for 10, 20 plus years, served our governments in many capacities, paid taxes. So, they are able to access some of the benefits here with Medicaid because or the PE. Now, if we were to move into IE, or individual enrollment, and that was a constant, some people were advocating for individual enrollment, and others were not for it. The disadvantages of moving towards individual enrollment include LPG, Medicaid, because if we do move into individual enrollment, what it truly means, now what's the eligibility slides, for example, if we move into individual enrollment, the only people that would be qualified for Medicaid would be U.S. nationals, U.S. citizens, children under the age of 21, and foreign pregnant women for local services. It is a room in Mafai and Medicaid, on a fire easy, au nanga I fafuatu, and may say lava more tato tangatanu, or in the Fananau, I fafuatu ma America Samoa, I would on North of Maui nature to Wina Mamanua. So, this 1902 J waiver, it's a lava the Medicaid, where in Fayay on a factor Nuina, Chena or Nanga or Ye Chinini, a Noa, Masi Fatsulangina made a federally. So basically, this 1902 J waiver is really helping American Samoa Medicaid office, especially with its the fundings, its programs, yama tulanga fatpena. The Medicaid state plan. You have heard about the Medicaid state plan, and if you scan the QR code in front of you for the Medicaid agenda and documents, you'll be able to access the Medicaid state plan. Now, what is the Medicaid state plan? Basically, we call it our Medicaid Bible. O mea umanava o tono the state plan, o I o lo ye guidelines I the whaatino ino na ngadwenga on the Office of Medicaid. We cannot do anything that is outside of this or not in the state plan. This is a legally enforceable document between the state, between us here in American Samoa and the federal government for medical services approved for federal financial participation in reimbursing claims. When a lot of the providers, new potential providers come to our office, we want to be a provider. Okay, we would have to check with our state plan. Services state plan. But also to see and how we do that, we call it a SPA. SPA stands for State Plan Amendments. Teno Services, as the director mentioned in one of her comments, when Medicaid started 40 plus years ago, the only provider there was here in American Samoa was LBJ. That was our only provider. And that was the only provider that was in the state plan. And so all these other new providers that we have now, from DOH with their FQHCs, to divisions, to Island Smiles, to DMEs, even the Off-Island Referral Program, they were all written into the state plan. The state plan amendment. Yeah, now how that works, we will get to that. The state plan consists of 7 sections, and if you are interested, it's quite a read. You can, again, scan it and read it. Yeah, it was written 40 plus years ago. So the language also, documents, the documents, and then sections 1 focuses on the EO of single state agency, 2, coverage and eligibility, 3, service general provision, all the way down to 4, 5, 6, 7. Why it is we operate this way. I think this will be a great read for you. State plan amendments. As I mentioned, what are some of the factors that the Medicaid office takes into consideration before we write these state plan amendments, before we onboard any new provider? We can't just onboard you because, okay, this is a service that is now available. Let's just onboard them. Let's provide, have them sign a provider agreement or enroll them into the Medicaid program. We have to first consider, number 1, the description of this additional services. We will go ahead and use orthodontics as an example. Island Smiles, Dr. Toko, they want to be a provider of the Medicaid office. Now, dental on Island is covered at LBJ and DOH. If free the dental in America Samoa. But what Dr. Toko and his company is offering is more than just the regular dental checkup they find in DOH. Yeah, actually for him an LBJ. Or they will offer my services to include braces, motomighty. Yeah, not cosmetic surgeries, but which are services that are not available in the LBJ, but the DOH. So 1, or the description now, or the service now, or the after on a tower, I'm not trying to find the study. Well, I'm not saying much of Dr. Toko, and my support officer. Okay, you've been around for a while. How many clinic? Yeah, data. Data collection is such a integral part of the Medicaid office because how are we to determine the need if we don't have data? And then, what is the cost? Yeah, negotiation because the cost of the clinic is not necessarily the cost that we are going to pay them. We would have to a closer clinic, fee schedules. We have to develop a fee schedule more so consider before we even write this new service into the state plan. Payment methodology, how are we going to pay them? And as Director mentioned, we have so much federal funding, but we are unable, each year we are unable to fully utilize because it is but the local match. Now over the years, there has been increase. We're not saying it because the House of Reps and the Senators They have agreed and over the years have increased the local match for the Medicaid fund. How about a round of applause for them? You know, come on out to no, I want na amat sa Maynava. It is a local match, and then we went advocated mawat sa milyon in local match. It's not much, but it was something. Fayon fangayoy nga duwe nga officer. Adwai wadwa milyon. Okay, we have more. There were 100 procurement of final referral. There were ngayon na 2 milyon. Adwai what solo milyon. Okay. There were final on board my DME division. There were paketsi in a ando uma procurement it's all. Adwai wa 5 milyon. Okay. There is now an increase, and now the Medicaid office has to show funding name we had to show now in the last couple of fiscal years we were fortunate enough to get 6 million in local match. Now it might not seem, and we are saying in later level, just the fact that we increase ileona miliona. What mafayana yay umalava services what include a orthodontics, well mafayana include a dialysis, what's in the expansion or the procalami. Now, to go back to the payment methodology, those are some of the factors that we need to consider before we even write a state plan amendment. Now, if everything is in order, and we've advocated, I don't know if I feel yeah, well, you don't understand if they see on board, they see a provider for one thing that we should know, a state plan does not happen overnight. It involves a lot of planning, a lot of back and forth with the providers. A while, as the director mentioned, once you submit a state plan amendment, it requires approval by CMS, the Centers for Medicaid and Medicare Services. Your office before in the mind. Okay, you have the funding for it? Why not? Go ahead. And so, in the last year, actually exactly a year ago, we got approval for Iron Smiles, and now you've seen the data since last year. What's in it to make you at least so to allow Elena Mafayana Fayana so a lot. Okay. Oh, I pretty much just explained all of these slides. Identifying of necessary changes, drafting the state plan, and then state review and approval. Okay, this is just further process on our end. Submit the response to CMS review process, final approval and implementation, and then key considerations to ongoing monitoring and reporting may be required to ensure the amendment is effectively implemented. Just because you are now a new provider to the Medicaid office, o fai pia le au nanga matsua le ana tato malidie o le a e providing i atunu. So o ina adwa so ma so banga program integrity, they will constantly come to see and do provider workshops, mafai provider visual audits ina ia multi-nonally o lo o yai au nanga ne tato. Now if we receive some complaints, yeah, my tato beneficiaries. Yeah, or enough. I might say no. Actually, they don't need a leo. I actually the officer is siaki. Yeah, pole actually naga de o yai mamia fakti na. Only now to ingalava. Ina ia to mau the quality or the care lena tato madidia. Ina nasa ina ia to songi pe ma so the pili. Ia fire pe o so de o nanga. Lena tato madidia. Again, how to amend guiding principles. Yeah, o me o malama yo tato then matana. It's just basically o me it's a considered officer before amending the state plan. Yeah, na consistent and enforceable, ensures uniformity in how situations are handled. Me o malama na policies it's a fatulangan lay mamana malama ya providers ya ato ay mad officer. O le alifa ngayon nga nila fayet hindi prokalami ya mana malama ya the process ina iyo may tangasa ide fituri na isolo ayo may sa level officer o umana ma yo me umanaba ma otsi level tangata ya nga ina iya mawan ni au nang. Hey, since last year, we have talked about standard operating procedures or SOPs. It's on officer. We are finally in a place where we want to test your theories. Okay, trial and error. What's out on policies? My procedures at officer. Yeah. In the last year, we were able to have training with Barry Dan, and I believe this training that was held in October really helped our office in completing our standard operating procedures. So we look forward to pushing out SOPs, policies, public information, or the transparency of the officer. Ina ia ilon nei yang avaa ma me tau na uia. I want to ina ina se mea mai na tunu. Yeah, so say mi na nei tau sanga. I want to wa tene na fa mau tu ina SOPs at the officer. Yeah, ye the fa moi moi. Ina nga te reo o tu inu. Yeah, a mata fo na post na tu ia tato SOPs. I may say policies on programs like taxi. Yeah, more than those see the fear the tato wa tunu. Yeah, pe yeni pisini. I said, "Sono fai unga naone." Or the presentation, it's just saying about the policy and planning. That was the end of the policy and planning presentation. Do we have any questions before we get to the questions on the slide? Okay, just to test your listening skills and comprehension, can anybody tell me how many sections there are in the Medicaid state plan? Christy? 7. Thank you, Christy. How many days? Oh, we do not go through that. What is the quickest way to get a state plan amendment approved? Or what is the process? Anybody know? So when Medicaid submits a state plan amendment or a SPA, who do we need approval from? LBJ? No. Who do we need approval from? CMS, yes. And what does CMS stand for? Centers for Medicaid and Medicare Services. Yeah, I find it a facility to say Tato Medicaid state plan, Tato state plan amendments. Yeah, to have any final comments for today, even if it's for a presentation that has passed. Any questions that you wanted to get clarification on before we identify my Tato Famoy. Sina, and awaia.
Leanga wate aitua i isi talanoanga ia sa ai ela lima lama la uile ia tama I information na I kape e qualify is it non-national pregnant women? Okay, can you expound on that a little bit?
Yes. One of the categories then what's eligibility that includes U.S. national citizens and all children ages 20 and under. And what's idea money foreign pregnant women or lawfully residing pregnant women in American Samoa for local services. So local services, umana ya ona timina o tere na whaingatau na toi travel ia tina whiangai maitanga. And the reason behind it is because
so lawfully residing foreign pregnant women, why we cover them? Because the assumption of their baby will be a U.S. national or U.S. citizen. So we cover lawfully present foreign pregnant women while they're pregnant and also 60 days postpartum.
Yes, and I think the act says no child left behind. Yung melan na o dewa yung assumption o pipi na wang tono na afa na umay o si sangatsa so tino sangatsa nuu America Samoa U.S. national ya ole alan na ya ado fo ilale care ili change fo ile fa ilele ya China se umalet sa usanga ya yang ba alabo ya mo care but for local services. Okay. Say si Kasili. Okay? Ya atonu wale so ya ini Kasili mo mata uku umana masasa no ina ne yaso. Ya aire I ya tatono de si ui fo ina sa so fa mo ni to la. You're a little bit ahead of schedule, but it is a faina. In the day for India, to have a noa. Yet my futai, Yamana, Yatway Aina. I turn Moniatu, the Ananga Fatsai 10 and Ama. Faido, Nefatsa Vama, Fongatomon Moni, or the Sungai, the Tamaitai Fatsono, Yalu is a choir. I may send a man on the officer. If I have a tie at Toy, but Yaman of Young Fatsono. O sui whaatonu, ia e mai se reo te denga lava o fo mai, ma the medical team, I so se capacity, whaafetai te le lava tau whaamalo o mai matala mai a langolango ina fo I whaamoe moe, I le whaangalo ina fo ina I tina maa tutua, o tata watu nuu, whaafetai le whaamalu mai, te wa mawadunga lava le whaamoe moe na medical ne aso ono o lo tau awai mai, ina ne ingalo, ia se tasi ia aolo sila le atua fa mania tele lava le anga ia tu ia inga a sa aper filiali ma tu wa man fo ia modio o atu le atua ro so so fo ma so ma so wona ia inga ro fa tan mai a o le asa tai ao te au dia tuai so ko atu le ola ma le so fo o le atu fa ai fa wa we sa so fontanga o le tu lai vai a ma tali ai o le valu le tatou breakfast, ia vave mai wasau madua tai au. Ia ona seki leo tatou mo le aso atoa tai au. Ia o le mātou upu lea matala, ia lo fangia le atua le anga ia tu ia ia. Whaftai te le lava mo le mātou wavanoa. Soifua ma ia manuia.